Sorry, I was just realizing that there's also a Teams invite on there. So I'm trying to make sure that that doesn't get too. Okay.
It's Rachel Zoom user.
Yes, it's me. I'm changing it. I changed it once to I didn't want to be shown where like that I was on there, and then it like created a fake account because actually Texas A&M won't give me a Zoom account even though I have everything else from Texas A&M. So I had to create one by myself. Therefore, it named me a Zoom user.
That is a way to be incognito.
Yeah. And then I was just Melissa Leonard just defended her PhD. So I had just called in for that, and it was like basically everybody there, and then it was like, and then me, Zoom user, like hovering ahead. And I was like, I swear I'm supposed to be here. What site name I would be. Oh, sorry, Mandy's trying to join the Teams one. Can you please join the Zoom version? Thanks.
Oh, I realized I was muted. I was trying to talk to you, but
It's all right. We've been doing this for how long, and I can't figure out how to not create a Teams meeting, and can't figure out how to unmute yourself.
it doesn't help when I'm not looking at the screen and paying attention to something else.
Yeah. Um, okay, I'm just gonna log off of this thing and then log back onto the other thing. Sleep you.
Sam Summer, I see you.
Let me get back in.
My plant! It's still alive. It's got a thing. Thought that was a bug at first. I was like, what the hell is that?
It's flowering.
It's a flower.
Yeah, it's kind of crazy right now.
That's a little
Yeah,
bit.
I have not killed it.
You're doing better than I did with it.
Okay. Hi, as we were letting people join, I apologize for the double invite. The invite that had the Teams meeting that was not supposed to be. Okay, Mandy is still trying to join the other one.
I keep trying. I'm gonna keep texting him on there.
Oh, it is recording already. Okay, that was my thing I was looking at. Can you send her also an email via Outlook? Since she is our presenter for the day, unless she's already here and I just don't see her.
Yeah. Maybe.
Okay, so as we're waiting for more people to join, We will have a few housekeeping notes. I apologize that the invite had a Teams meeting link that was not planned. It is now auto-populating itself as creating a meeting instead of making you tell it's a meeting. So I forgot to uncheck that box. And so we're trying to do these via Zoom. That makes it easier for archival purposes. Also, it's what JD prefers, so we like to keep JD happy. Uh, so, and as much as I would probably fight back about Teams not being so bad, Teams has been a real jerk this past week. So, I'm okay with getting angry right now at the way that Teams is behaving. So, um, I will try to write myself a note to make sure that I always uncheck the Teams meeting part so that it doesn't alert you guys to join a Teams meeting for next month's session. And as I will double check the date to see if it might be during, oh no, it's not during ACVIM, so we will still be able to have rounds on June 17th. So we will send the invite again for at the very beginning of the month to invite people to participate and choose a case to discuss. We occasionally have been doing kind of pop quiz questions. I was kind of thinking today's case is pretty complex, so I was planning on doing it without quiz questions. However, some people seem to like them. It's kind of fun. So we will probably resume that maybe in June, but today's case is a little complex. And we are waiting for the person who is presenting it because she got misdirected to Teams as well. So that's my fault. Then in general, if you know of other people that would like to join or be invited, please forward them to me. We will add them to the distribution list. And if you have noticed that you have not been invited recently, and I actually noticed that Dr. Lees hadn't attended a couple of times, and so I was wondering if he accidentally got kicked off of the invite list. Dr. Lees, were you kicked off accidentally, or were you just busy? I saw you were on here, so I'm not sure if you're muted or not right now.
I'm here and had conflicts.
Okay. I just want to make sure it wasn't something. So we've had a lot of people accidentally been kicked off, especially like even Dr. Hokamp of her own meeting has been kicked off. So there it is haphazard when they decide to create and distribute the distribution list. Or maintain the distribution list. So don't feel bad about asking like, why haven't I had an email? Why haven't I had an invite? We usually look back towards our distribution list and realize for some reason somebody got bumped off the list. And I see Dr. Spillane is joining, and I was just explaining to everybody that I apologized that there was a Teams invite at one point because Teams auto-populated an invite on the meeting thing, and then there was, so I need to remind myself to always uncheck that part. But this is being held with Zoom. It makes it a little bit easier for Summer, who does our kind of maintenance of the ACVNU repository. She can just take the Zooms that we have recorded because they're basically recorded in the ACVNU account. And then she can archive them appropriately as opposed to the workarounds we were having to do when everything was through the Texas A&M. That's long and beyond here nor there, but it's just there's more extra steps. So hopefully through Zoom it makes it a little bit more smooth. And if there are any other questions or comments from anybody, also Jessica, is Friday a short day for you guys? So nobody's receiving biopsies on Friday?
We'll still be receiving biopsy.
Okay.
Oh, am I muted?
What?
Oh, no, I'm muted
You're
on
good.
that one. Sorry, I've got the teams going
It's fine.
on here trying to get people to move. We do have a half day, but we are still receiving samples, so we're all good.
And then, but 4th of July situation will be different or no?
Fourth of July is, since it is a
It's a weekend, right?
male holiday, yeah. But since it's so anytime that it's like a male holiday or shipping holiday, we can't get anything. So if the postal service isn't going to be delivering, or if
Is Texas A&M taking a day off though in honor of it? So like the Friday?
Yes, usually I'm pretty sure I'm gonna double check on that, and I'll make sure I update that on our website.
Okay.
Well, and not that we should be getting samples hopefully sent over the weekend to arrive on Monday, but Monday is a holiday.
It
Yes.
happens.
So
Well,
please do not send anything to arrive on Monday.
it does
Yes.
happen, though.
So yeah, so please be aware. And plus now I guess we should also do the Texas is getting hot.
Texas is getting hot. Use a lot of ice packs. Use insulation. Insulation usually involves some sort of styrofoam based something or other. I hate styrofoam, but reuse it. It's getting so hot. If you think it's hot, it's hotter than that, and you need more ice packs.
Yeah. So we're getting to summertime, and that means that Texas has already been in summer for about a month already. So just be aware when samples, and then also we always, as a public service announcement, like let us know when things are coming, whether that if you're friends of ours and you want to text us, that's great. If you just want to send us a quick email, say sample it's on its way, that helps us a lot to be alerted to when things are coming in. We need to look for them. So that can be very helpful. Okay, so Mandy, I apologize again for the misdirection for the invite, but we would love to discuss the case for today, Flounder. And also, I sent the invite to Russ. I think he's on here. Dr. Moore is on here as well from Colorado State to hopefully give us a little more insight into the type of disease we're going to be talking about. So, do you want to start your discussion for the case, Mandy?
Yes, I would
Okay.
love to. I'm going to share my screen just so everyone can see. I didn't prepare anything, but I have this lovely EasyVet chart that summarizes some of the pertinent info. So Flounder is a pretty complicated case, so excited to discuss and get everyone's opinion. He is a 10-year-old male castrated greyhound that found me in an interesting way. But essentially, kind of to start with, he is not clinical for anything going on, so that's great that he feels good. He essentially found me a little bit over a month ago. He was under anesthesia with our dentistry service because he had a squamous cell carcinoma in his rostral maxilla, and he was under anesthesia for a CT for surgical planning of a maxillectomy. The CT included his head, his thorax, and 2/3 of the abdomen, in which a portal vein thrombus was identified. And kind of going back through his history, he has been managed for PLN for almost a year now. He is a greyhound, so his creatinine normally will be a little bit higher than the typical, but despite that, he does still have a mild azotemia that's been pretty stable for the last year up until kind of April, where it was a little bit higher than previous at 2.9. He did have proteinuria. We can see the UPCs listed here, but he initially had a UPC around 3, trended up slightly to be around 5. When I saw him, and historically his PLN has been managed with benazepril, which the dose was increased as it wasn't working well. He was transitioned to telmisartan, as well as kind of mostly a renal diet, although he was getting some non-formulated kind of home-cooked food, as often will happen in Los Angeles. So he was managed with an internist. I kind of found him at the point of the CT. When he was under anesthesia for the CT, he was hypertensive. They also found a thyroid mass as well. So the poor dentist was a little bit overwhelmed with all of that. So ultimately we decided to postpone the maxillectomy, wake him up to kind of sort out these other things. So what we did that day, is we did aspirate the thyroid mass. It came back concerning, but not definitive for carcinoma, as they often do. On his CT to note as well, he does have pretty severely enlarged cystic lymph nodes. So that was a little bit interesting, although kind of hard to know what to do with that. What we did, so the other thing to note is that he's also had a hyperglobulinemia chronically. He had never had a serum protein electrophoresis done, so that day also submitted a serum protein electrophoresis, which perhaps I should show the actual trace for that. But that serum protein electrophoresis came back as either a split monoclonal or a pseudo monoclonal gammopathy. Let me actually find the tracing. Let me just dig through my email because that will actually be the fastest way to find it, as Dr. Moore has been helping me. Okay, here we go. Just ignore my email. But this is the
I
actual
think we still only see the
Oh, really?
yeah, the
Okay.
easy bet.
Okay. What about
Yep,
now?
that's good. That's good.
Okay. Okay. So this is the serum protein electrophoresis that was submitted in April of this year. Just the other things to note is that Flounder did have an STS page submitted August of last year when he was being managed for his PLN. And that revealed severe glomerular damage. There was no bands above the 200 kilodaltons concerning for immune complex. However, just came back non-specific. And then what else do I have to say? So yeah, ultimately that day when I inherited his case, we did a bit of further investigation, started him on rivaroxaban for his portal vein thrombus, but also recommended a kidney biopsy, as the concern was that his uncontrolled PLN was making him hypercoagulable, leading to the portal vein thrombus. So we did end up doing a kidney biopsy, which is how we come on to this meeting to discuss the results. Did a percutaneous kidney biopsy that went quite well. We have the results for that, which I'll leave Rachel to talk about. Just the other kind of update since then is that he did have his maxillectomy and he had a thyroidectomy performed a couple weeks ago now. That all went really well. In terms of the plan for the rivaroxaban discontinuation prior to both the kidney biopsy and surgery, it was stopped about 24 hours beforehand. He did great. He started back on it the next day. He did come back for an ultrasound about a week and a half ago, just to reassess his portal vein thrombus and see if we were seeing improvement in it or not. And it did look about the same size. So at that point, since his procedures were done, increased his rivaroxaban dose, as well as started combination therapy with clopidogrel. On the ultrasound, to note a couple of things that weren't noted on the prior ultrasound with the internist that was managing his PLN, but he does have a target lesion in his liver, and then his spleen looked a little bit mottled, and obviously still has the cystic lymph nodes. So I think the question I have, which I don't know if we have the answer to yet, is does he have IgG4 disease, which we'll talk about, versus multiple myeloma? When he came back for the ultrasound and then we kind of got the final kidney biopsy results back, which is where Dr. Moore comes into play. Did submit both serum and urine for a little bit further testing in terms of electrophoresis, but then also the immunofixation protocol that they do at CSU to look for the IgG4 levels in terms of that disease. So that's kind of where we're at. I'm sorry if that was a little bit all over the place, but quite a bit going on. Good news is he doesn't feel clinical for any of this, but I'm trying to get on top of it. So I'll hand over to Rachel at this point.
Yeah, this is an interesting case. Obviously there's a lot of comorbidities that are present in this patient. So just as we're starting, how many of you guys, if you, let's I'm gonna look at the whole group. I'm gonna see if how many, can you guys like do the little Zoom raise hands if you've heard of IgG4 disease before? Let's see. How do I want to view this? I want to view multi-speaker. Who's here? Who's heard of it? Nobody's putting their hands up. Okay, we've got one hand up. Anybody else?
Heard it from me, y'all.
Yeah, same.
Okay.
I've heard of it, but I don't know how to say so here.
Okay, so the hands up, yes. Okay, so
I've
or you
heard
can
of
put it
it
in chat if
now.
it's something you're familiar with. And I'm not entirely sure that this is what this is going to be, because when we've done extra work, it's really going to be hard to figure out how to diagnose it, especially when we're talking about dogs. But it is an entity in human internal medicine. And it doesn't just affect the kidney, it's multisystemic. So my familiarity with it comes from having been and working with a lot of MDs and then being and diagnosing kidney disease at UNC. And even in human medicine, it's a very vague diagnosis. It is kind of like you get whiffs and hints of it on the biopsy, but you really do need the molecular data to support that the plasma cells that you're looking at are secreting or synthesizing that subtype of immunoglobulin G. So it is not a pathognomonic picture on pathology. It's just one of those things where you're like, huh, that seems a lot of plasma cells, way more than I would expect. And so then you start to do additional testing in order to get supporting evidence and to make that diagnosis. This is kind of the question that we have for this particular case. The other comment is that, yes, it is a recognized entity or syndrome in humans. It has been reported by the Colorado State folks in dogs rarely. I think there's two cases so far, two. Okay, but we very well might be missing it because we don't do all these diagnostic tests to see the breakdown of the lineages of the IgGs that are being synthesized by the plasma cells. But even recognizing it exists as a disease is kind of the first step, and then kind of getting better characterization of what it looks like in veterinary medicine, and then maybe it's just a canine analog of a human disease, so it may not be able to meet all the criteria that you would meet for diagnosis in human medicine. So I'm going to start sharing my screen because the point of this is that we are in kidney rounds, so we are going to look at kidney pathology. And it's gonna do, of course, now it's going to want to do that. Are you guys seeing my
We have your Google page.
Okay, cool. Okay, but I want to show you this. Now you're seeing the slides.
Yes.
Okay, perfect. Okay, so biopsy cores are submitted to us. We get multiple different samples, and we get samples that we perform histology with special stains. We get a sample that that comes also in the formalin, and then we process it for electron microscopy. And then we have the benefit of also getting a sample that is not fixed. It's submitted in saline type medium, not true saline, but just a buffer, a transport buffer. And so that sample gets sent to us. We wash it multiple times, and then we embed it in OCT. And that's the sample that we use for our immunofluorescence. So I'm explaining a little bit more about this just because not everybody on the call understands the ins and outs of how the biopsies are performed. Or processed, I guess I should say. So let's start with our histology specimen, and this is the H&E specimen. We got 3 good, I think this is one fragmented core here that's quite long. This core here is mostly medulla, and then we have another core of cortex. So as we examine the samples, the dog has frustratingly different kinds of problems that we have to deal with. So we know the dog has proteinuria and has had long-standing proteinuria, and that we know that a previous SDS page, which looks at the size of proteins that are lost into the urine, and it was done last summer, or basically like kind of end of last summer and maybe last fall, had evidence of severe glomerular damage and really no specific thought or mention of the tubular interstitial injury. But as everybody is looking at this core, there's a lot of density of cells in between the tubular profiles. So we're looking at an H&E, which is helpful for us to identify what kind of white blood cells would be in between the tubules. But you can see the tubules are sometimes widely dispersed, and they are not, the whole core is not just a whole bunch of tubules back to back. So you have to travel sometimes quite far distances through the inflamed interstitium in order to find to the next tubule. So here actually is a fairly healthy looking tubule. And then this tubule over here is undergoing atrophy and degeneration, but there's a lot of space in between those 2 areas, and it's filled with cells. And so it's quite a striking amount of inflammation. I look at a lot of kidney biopsies, and oftentimes we find patchy inflammation. It's usually on the range of maybe, I don't know, a few cells here, a few cells there, but not as separating or damaging of the tubular interstitium. Hold on one second. I'm getting little alerts from, oh, I think somebody else is rating in the
Hear of
Teams
it.
chat. If you wouldn't mind helping us, Jessica.
Yep, I'm on it.
So quite a lot of space in between one tubule. Now this is a damaged tubule, and we have another damaged tubule over here, but we have so much space that's just packed full of inflammatory cells. And there are lots of regions that have healthy tubules that are still separated by inflammatory cells. So the inflammatory cells themselves are quite the classic picture that you remember from vet school histology, where you have a round nucleus, usually a center nucleolus. Sometimes you actually even have the stippled clock face. Remember that from histology way back when. You have this gorgeous Golgi area, which is our little perinuclear halo, and then you have a peripheral rim of basophilic, kind of amphiphilic cytoplasm. And so a lot of these cells are that same appearance. So that's very plasma cell dominant. Occasionally you might have intermixed regular old lymphocyte in here, but a lot of them are that plasma cell appearance. And the other thing is that they are just very closely intermingled with fairly normal or mildly dilated tubules. Now, as I've said, there's a lot of chronicity here too, so we have some evidence of previous damage, but this isn't just areas of really scarred tissue with a lot of interstitial fibrosis associated with the plasmacytic inflammation. It's literally plasma cells just kind of being throughout the entire core. The other thing is when we have a really bad interstitial nephritis case, like a true attacking of the tubules, let's say like a true like leptospirosis type disease process, oftentimes we'll see the inflammatory cells being able to cross the tubular basement membranes and be inside and migrating in between the tubular epithelial cells. And we don't see that in this particular case. Even our damaged tubular epithelial cells our damaged tubules don't have infiltrating inflammatory cells that are kind of homing to try to get at the tubular lumens. So I was struck by how much plasmacytic inflammation there was. It's not as prominent in the medulla, although it's here. Again, plasma cell dominant. And then it's also in our other core as well. Again, lots of regions with healthy tubules and then a whole bunch of plasma cells just intermingled with them. So that's what's going on for the striking feature. And then most people do biopsies because they're interested in what's going on with the glomeruli. Obviously,
Rachel,
again,
one quick
yes.
question. Is there a difference between calling it inflammation or plasma cell infiltrate, or no distinction?
So I think I bottom line this as plasma cell rich infiltrate because I'm not entirely sure they are doing an inflammatory job here. So it's
Well,
almost like, is there, and that's kind of what we'll get into, kind of what are these cells doing? Are they a clonal population? Are they reacting to something? Or are they just here in slightly like smoldering proliferation? And so that's kind of why I'm a little leery to say it's a nephritis. Or if I did say
okay.
nephritis, I said dominated by plasma cell infiltrate.
Yeah. Okay.
But yes, that's a good point. It's not like they're truly seeming to be reacting to something. Any other questions about the plasma cell population? Okay, I'll have more images and stuff like that about other things we'll do to further characterize these. Okay, so then most people will do biopsies because they're interested in what's going on with the glomeruli. We had a lot of glomeruli for this. I think we had like 30 or something, or quite a few, but actually most of them were like this glomerulus here and this glomerulus here, which hopefully you guys have called into enough conversations to understand that these don't have any patent capillaries anymore. So they're basically just big balls of collagen with maybe a few entrapped residual cells. And so maybe we have two little tiny capillary loops on this particular glomerulus, and this glomerulus is completely obliterated by collagen. And so when you have glomerular accumulation of collagen, we call that sclerosis. We do not use the term glomerulofibrosis unless there's a very specific disease, but in general, we say glomerulosclerosis. I say this every month, but I will say it again. The reason we don't say glomerular fibrosis is that these are not fibroblasts synthesizing the collagen. This is collagen, but it's being made by mostly mesangial cells, as well as the endothelial cells that are trying to make basement membrane collagen. Podocytes are making basement membrane collagen, and all of that is just normal matrix that would traditionally exist in the glomerulus. It's just excessive amounts about it. So because of the fact that it's not a whole bunch of fibroblasts in the glomerulus synthesizing fibrillar collagen, these are not, if you do EM on these tend to not have a fibrillar appearance. And because of that, we don't say glomerular fibrosis, we say glomerulosclerosis. It's just a nuance, but it's part of the way we use those terms. So as you start to go through, and when I switch to a different stain, it'll be even easier to pick out these whole globally sclerotic glomeruli. But most of the glomeruli in this specimen were globally sclerotic, and only 3 were not. So only 3 were actually doing all of the work of this particular region. Obviously, the dog has more glomeruli, but we only had 3 visible that we could assess for evidence of glomerular lesions. So one of them we were over here. And even though I said he was not globally sclerotic, I personified the glomeruli. I shouldn't give him it's not globally sclerotic. It is still not normal. There's still way too much matrix in here. And right here we have a podocyte who's got some protein droplets, and another podocyte who has a hypertrophy of his cell and prominent nucleus, kind of pointing towards Bowman space. The capillary walls are actually not very thick when you're looking at a non-sclerotic region. They actually look like they're fairly normal in thickness. And so even the 3 glomeruli that we're able to filter are not actually normal. I think there's another one up here somewhere. Maybe it's further down. I think it's, and they're also a lot easier to evaluate on the other stains. So let's go to the other stains. I can actually just do this one. I'm just gonna tab through. Sorry. Okay, so here's our PAS. And again, it's gonna highlight now a lot of these guys that were kind of just blobs of pink regions in the H&E section. They can pop out a lot easier. So you can see there were a lot of glomeruli even in that top sample that weren't really obvious in the original H&E because everything was just kind of pink, but they are quite dark and they pop out a lot more easily visible on the PAS stain. So we have quite a few globally sclerotic glomeruli even on that one smaller top sample. And then if we go to our bottom sample that had visible glomeruli, this was similar to the one we were seeing before on the H&E. We have expansion of the mesangial zone, probably a little bit of hypercellularity within the mesangial zone, but the capillary walls themselves actually are fairly normal thickness. And so we often like to compare the capillary wall, the glomerular basement membrane, to the basement membrane of tubules, and they seem to be about the normal, a similar thickness. And so that's within the realm of normal. It is wrinkled. Can you see how squiggly it is? We often assume that the squiggliness, the wrinkled appearance of our peripheral capillary loops is associated with kind of ischemia to the tuft. And that would make sense, right? If we wanted to make up a story that we have blood coming into this afferent arteriole, it's quite thickened walls, and we have a lot of matrix that's kind of compressing that arteriolar pole. So it might be that this particular glomerulus is hypoperfused, and because it's not as well perfused, the capillaries start to kind of wrinkle and have that kind of wiggly appearance at the peripheral capillary loops. We have another glomerulus out here. I think he is the identical glomerulus we were looking at on H&E. This is all of that extra matrix, and actually also there is plasma that's being pushed out here into the portion of the capillary tuft. We call this lesion with that bright fuchsia color hyalinosis. There's hyalinosis of Bowman's capsule basement membrane as well. The podocytes, again, have those protein droplets. Here's probably either a podocyte or a parietal epithelial cell. This guy's a parietal epithelial cell. These guys are podocytes and parietal epithelial cells. So a lot of protein is getting pushed into Bowman's space. And the podocytes, ooh, this is a great one. This is a good podocyte that's trying to reabsorb as much protein as possible that's being lost through that segment of the tuft that's leaky. So we have segmental sclerosis, we have abundant global glomerulosclerosis, and I think there's one more out here. That's another segmentally sclerotic glomeruli. So even our patent glomeruli have evidence of glomerular injury. Here's more podocytes with protein droplets. So they have been working long and hard to try to reabsorb as much protein that's gone across the glomerular filtration barrier. But obviously some of it is still leaking and it's still getting out into the urinary space. The next thing I'll show you, I think, is the trichrome stain. Yeah, so here's the trichrome. This is, again, going to pick up those glomeruli that are completely globally sclerotic because they're just now big, huge balls of collagen. So it's going to highlight those. You're going to see that there is some interstitial fibrosis, but some of these areas like here where we have separation between the tubules, these are actually just a whole bunch of inflammatory cells. It's very minimal amounts of collagen in that area. So some of it is undergoing fibrotic scarring, but others are just a whole accumulations of white blood cells and mostly plasma cells in that interstitial region. And we will go back to our glomeruli to highlight how much collagen is being pushed, or sorry, how much collagen is in the segmentally sclerotic glomeruli. This is what hyalinosis looks like on a trichrome. It looks kind of orangey. And let's go back to this guy over here. So you can see we're at different levels, right? So certain areas will have, you know, a different depth of the section of the glomerular tuft. But the silver stain was fairly non-exciting. I didn't see evidence of remodeling or things that would make me worried that there were deposits that was resulting in GBM remodeling. So we're looking at our capillary wall, and it's a tiny bit out of focus, but you don't see any of those really good spike projections that we see with immune complex disease. You don't see double conjuration. The other thing is that the areas that are segmentally sclerotic have still a silver, they still are able to pick up silver material, which means that expansion is due to basement membrane material and not due to amyloid. So if this was an amyloidotic glomerulus, all of this would be pale. You would have no staining in here because amyloid fibrils would not bind to the silver. But because it's just regular general collagen of a normal glomerulus, it does pick up the silver, and that's why you have black staining there. It's kind of got some debris on it, but you can see, and that's a little bit out of focus, but you can see that the capillaries themselves are not showing evidence of GBM remodeling. This is all what we would see with like hyalinosis, which is what we saw in the glomeruli with the really bright pink stuff on the PAS, the orangey stuff on the trichrome, and on the silver, it kind of has this kind of like hazy brown color. Okay, so we had emailed back and forth. We knew we were going to get extra stuff done on this case. We went ahead and requested a MUM1 to see how many, if we could highlight and show us how many plasma cells are in these populations. So it is a good way for us just to get an estimate that a large portion of these infiltrating cells are plasma cells, and probably these guys here that are intermixed or maybe just the lymphocytes. Now this just tells us the entire plasma cell population. It doesn't tell us the subtypes of plasma cells. But you can see there's entire regions where it's just mostly plasma cells in that interstitial region. And the next one I think the previous one was just the MUM1 negative control. Is that what that one is? Yeah, this is our negative control. So negative control, pretty good. We had the next thing we did, which I need to stop sharing here so I can bring up my next folder. Any questions so far? Anything? All right, I'm going to show you the best. There's a lot of material in here. So one second, let me figure out the best way I want to show this to you. So our next step is usually time sequence wise is to get the immunofluorescence and the IF for this case. Actually, there were a couple of a lot of the glomeruli that were present in the specimen were still segmentally sclerotic and not great glomeruli for evaluation. I will show you this one. This is actually, let me get to the better IF, sorry. So I think we had 2 or 3 pretty good glomeruli in the IF specimen. It's interesting, and I know we were talking before about the IF labeling of this. And so sometimes our IF is beautiful and pristine, and then sometimes it kind of does this where like everything seems to be able to label. And especially with the IgG antibody that we use, And so we were emailing back and forth with Dr. Moore, and he had asked if there was evidence of the IgG labeling the core. And so this is just kind of a bland, everything is the same strength. So I did not take this to be positive that these cells out here were the plasma cells. This particular FITC labeled IgG is touchy about when it decides to label everything versus not label everything. So here's where the glomerulus is on a different antibody stain. So this is against IgM, and you can see here is all of our tubular interstitium. And it is not uncommon, and oftentimes we wonder if it has something to do with like a little bit more formalin exposure, and maybe this antibody's a little bit more touchy, but we'll have times where like everything seems to stain positively for the antibody when that is used for IgG, to detect IgG. And now what we're using these antibodies for in general are to try to detect deposits in the glomerular tuft. And in the IgM, oftentimes we had a lot of serum and hyalinosis that was pushed into the glomeruli that we saw in histology. And so because you have a lot of IgM just hanging out your serum, oftentimes we'll see a splotchy appearance, just as a non-specific staining pattern with IgM, which is present on this guy. And it can be quite intense. It can be quite positive. But it's just a typical thing that we would see in areas of sclerosis and hyalinosis. And so the lambda would also tell us if there is immunoglobulin there, because it's the light chain of most immunoglobulins in dogs. And so again, you're going to see, because you had a lot of IgM there, you're going to see a considerable amount of lambda as well, but it's a very like, we use the term splotchy, just means that it's not a granular dit dot pattern. And the lambda didn't seem to label stuff that was in the interstitium either. I actually even had them, this is probably right here is a podocyte that has a whole bunch of those protein droplets in it. I did ask the lab to go back and take photos of the lambda of the interstitial cells to see if we could have any regions, like this is just interstitium, to see if we would have any plasma cells pop up. And I didn't see any that was being labeled with the lambda cells, sorry, labeled with the lambda antibody. These are tubules right here, and there's really nothing in between the tubules. This particular piece might not have had a lot of the plasma cell population in it. When we do this in humans, and obviously the antibodies against human proteins are so much better and so much more specific, but if you had an IgG4 disease, you would actually see gorgeous little outlines of plasma cells on the immunofluorescence when the sample contains those a lot of those plasma cells, and you would see it whether it was lambda or kappa. It's usually lambda. Okay. And then the other thing is we did look and we took a picture of the frozen specimen because I was curious to see if the frozen specimen really did have a lot of the same appearance for plasma cell population. And the frozen specimen was quite small, and it didn't have the great focus of plasma cell infiltration that the histology had. Lastly is kind of boring because it's the EM. Well, it's not boring in my opinion, but it is not as exciting as the rest of the story. So, but the EM shows us that there is no evidence of immune complex deposits. So here we are looking at the capillary wall of the glomerulus. The GBM is right here. It's encircling this little area. This is an endothelial cell nucleus. And we have evidence of podocyte injury. All of these podocyte foot processes are lost and they're effaced. They're basically no longer maintained. But there are no deposits within the capillary loop itself. There's also no evidence of amyloid fibrils, because that was obviously a possibility given how many plasma cells were here and the fact that there was proteinuria in this patient. But this is what you should see for podocyte foot processes, you should see like little blebs of cytoplasm that are running perpendicular to the axis of the capillary loop. So here we've maintained about 5 of the foot processes, but all these other areas are completely effaced. And so that makes sense with the fact that this dog is so severely proteinuric, and also with the fact that the podocytes were injured on histology, but the actual cause of what's damaging the podocytes remains unknown. So I'm going to stop sharing. We've had a couple more, so you guys were able to run protein electrophoresis on the serum and urine. I'm going to turn it over, if that's okay. I totally invited you this morning and I was like, you should join, and now I'm putting you on the spot. I'm the worst. I'm not sure. You're not muted, but I can't hear you. Is anybody else having problems hearing?
Yeah, I can't hear either.
Okay. It may be just that your mic's off. Sorry. Now I feel really bad. I feel really bad. I literally just emailed him like, hey, we're going to be discussing this case. So I was like, feel free to join. He's just going to attach his mic. So as we're doing this, there is a disease, which is basically when plasma cells that have a specific subtype of immunoglobulin. So in humans, there are 4 immunoglobulin variants that can be synthesized. Are you good? I will continue just to keep talking for a moment.
Not so much, huh?
Oh,
Okay.
yes.
Okay, good. Okay. Just had to switch. They had to change out my microphone and it's still not functioning here. Okay. So, and I anticipated that I'd be prepping or presenting a little bit. So I've got stuff kind of prepped for that already. Okay, can I share screen? And I need to remember for you that, share that guy. Okay. And I need to remember that I'm working on a massive screen, so I need to make it really big on my side. Can y'all see that information well? Okay.
Yep.
So, sorry. We got electrophoresis of the serum and the urine and immunofixation. I'm showing you here our run on the serum, and I've got the electrophoresis of the urine back. The immunofixation is staining right now. Kind of go background on this kid. We use an agarose gel electrophoresis, so that's non-reduced. We're seeing both size and charge with that, which is why it's going to look a little different than what we see in the SDS page. And the previous, this kid here, that looks to my eye like this is a capillary zone electrophoresis. That's how those usually pop out on that image and that pit. So we've got like 3 different techniques being used electrophoretically in this patient. Getting back to our AGE. So standard size, charge, separation. Albumin's going to be over here on the left. We typically break out into 6 fractions. And then we've combined that with immunofixation. For those of you who are unfamiliar with that, it's like running a Western blot, except we do it in the gel itself. There is still a blotting component, but it's run with a wet gel, and we're actually pulling things out instead of trying to transfer stuff around. This first lane is the whole serum. It should mirror this and this piece right here, okay? And then we use targeted antibodies to identify immunoglobulins in that sample. Lane 2 targets the IgG-Fc. This gets IgG subclass 1, 2, and 3. It does not get IgG4. Lane 3 is IgA. Lane 4 is IgM. Lane 5 is light chain. And this gets both kappa and lambda. It does not separate out based on light chain class. And then lane 6 over here is going to be an antibody that targets IgG4 specifically. And what we can see here is that we have that same kind of peak going on in the beta 2 gamma region that we had previously. And that labels fairly diffusely with IgGFC and associated light chain. There's not much in the way of IgA, IgM, and there's no IgG4 present in this sample. On the urine sample, to kind of get to that one, like I say, I've got the PE together. The IF is staining downstairs as we speak. A similar thing, let me make this bigger. Too big. Back up. There we go. A similar type of a profile here. Albumin's over here on the left. Well, actually, it's easier to see this, at least in my mind, easier to do this for me if I go to, this is actually in the analytic system, and let's jump back here. So this purple tracing that we're looking at here, in this one, the purple is the urine, the yellow is the patient's serum sample. And the piece that I pick out as I'm looking across this is that, yes, we've got proteinuria coming into it, but we've got filtration going on as well, filtration and absorption, in that we still have that immunoglobulins kind of leaking on through. We've got other globulins passing on through, but in the urine sample, the purple, they are less proportionately to the total protein than we have in the serum sample. And so the glomerulus and the tubulars are doing some amount of job. This looks like maybe a touch of a glomerular to mixed proteinuria based on this preparation. So the question that we had on this one was, is this patient an IgG4 related disease? We've found a couple of those, more than what's been published, but not many more. And there's a group out of the UK that has identified them as well in pancreatitis. IgG4 related disease is a syndrome. It's a bunch of different entities that have been kind of mashed together. They have lots of IgG4 expressing plasma cells. They have a storiform fibrosis. They've got an obliterative phlebitis, and they produce masses that are big and frequently get called neoplasia because it looks like it's a plasma cell tumor. Rachel, on your preparation, as I was looking at it, it doesn't look like we've got the fibrosis component in significant amounts there. Is that correct?
Yeah, the storiform fibrosis can be kind of so depending on what stage you get it from a human biopsy, it depends on when you might actually see the fibrosis. But the other thing is that even if it has a mass lesion, it's not, so for the pathologist on the call, we all know that a plasma cell tumor often has abnormalities of the cellularity. So like the cells can be quite large. Even a benign plasma cell tumor can have, karyomegaly, multinucleation, and stuff like that, and mitotic figures. And so the IgG4 accumulations in human kidney biopsies, even if they have a mass, don't have a lot of mitotic figures. They don't have a lot of cellular atypia. They look like mature plasma cells. And so there are serial biopsy studies where they've looked at multiple, like a patient that has IgG4 disease over multiple years of his life, and you can see that occasionally, the very beginning, there really honestly isn't a lot of fibrosis, but then by the time 3 years later, there's fibrosis. And granted, a human is living much longer with this disease, and so we can get quite a lot of length for multiple serial biopsy samples. So But yes, you're right. Especially in in some of the biopsies, the fibrosis that can sometimes be more dominating than the amount of plasma cells.
And similarly, my understanding is that in some IgG4 related disease patients in humans, they don't have significant amounts of IgG4 in the serum, right?
Yeah, that is true. And they also because as it can be multisystemic, they often have inflammation or infiltration into their pancreas,
Mhm,
salivary glands, kidney
mhm,
is kind of like the side. It's not always present in the kidney.
right.
The and I guess of the dogs that have been published, have they seen the plasma cells within the kidney, or is it mostly based on clinical, or I guess not even the dogs that have been published, but the dogs that you've been
That
accumulating?
we've seen. Yeah, I've not seen a kidney-related IgG4 in the dog.
Okay.
Head and neck, um, and then some of the English Springer Spaniels, I think it is. In one of the English Spaniels, there was a series that was done out of the UK that found pancreatitis, idiopathic pancreatitis, that mimics IgG4 related disease, and they were making a claim for that.
Got it.
But
Yeah.
no,
And
I've not seen the renal form.
I think that the difficulty with trying to jump between species is obviously the plasma cells are here. They are
Mhm.
implicating something that is almost like it's not responding to a specific infectious agent. The glomerular disease is probably why this dog is so proteinuric. But the glomerular disease has been long-standing. We've had that proteinuria for quite some time. So who knows what the original cause or insult was. The other thing is that the in human diagnostics, when plasmacytic IgG4 disease is suspected in a kidney biopsy, again, it's a lot of just finding the whole bunch of plasma cells, plus or minus having that amount of fibrosis. And then they often already have the serum protein electrophoresis. And so they would know that there is an IgG spike. They would have the background to then look and see if the urine or the serum have IgG4 as part of that subcomponent. But then honestly, it's so annoying because the final diagnosis is basically they do an immunohistochemistry to label the plasma cells that are expressing IgG4 specifically. So they have an antibody, an IHC antibody against IgG4. They stain their kidney biopsies with it. And it's literally like it's a vague number, and even the nephropathologists will tell you this. They came up with this idea that if more than 40% of the plasma cells that are in the biopsy are IgG4 plasma cells, that warrants the diagnosis. And you ask, well, what is the difference between 38% versus 42%? And they said they don't know, but 40% seems like a good number. So, so even in human nephropathology, it's kind of a vague entity. The cool thing is that it's pretty well managed with steroids.
Yep.
And so a lot of times response to steroids also helps back that diagnosis. But when I was at UNC, granted many years ago, gosh, a long time ago, we had a patient that had like 4 serial biopsies and like would be on steroids, and then would we read biopsy and the plasma cells would be gone, and then it would have another flare, and then the plasma cells would be back. Oh, thank you so much for that, Mandy, about the lepto testing. So there's something here. There is a plasma cell infiltrate that shouldn't be there. PAR was negative. We did have PAR clonality, which Mandy put in the chat was negative. So these don't seem to be a clonal population. Now, are they a class limited population? And that's what we were trying to figure out. We can say they're not IgG4 plasma cells, but could they be a class limited for the other subtypes of IgG? Are we still really good at being able to subdivide out the classes of IgG? We're not great in my experience in veterinary medicine for that. And the other thing, which I'm glad Mandy put in the chat, is that we always used to have like a lot of old school pathologists tell us that when you had a really plasma cell rich nephritis, like a true nephritis with really good evidence of tubular damage and tubular injury, that lepto should be very high on your list. But it does look like that we don't have other supporting clinical evidence of leptospirosis. So this is kind of a mystery case, and I'm not sure if anybody else on this call that has done kidney biopsies has had a similar type of diagnosis. Okay. Yes, thank you, Maggie. But you also aren't looking at dogs. You're looking at sea mammals.
The only other
So
thing I'd add is it's in press right now, or it's in review right now, hopefully
Okay.
in press soon. The PAR assay, we ran, I believe, the routine PAR, which is targeting heavy chain. And when I did a retrospective on that, looking at performance at picking out plasma cells, it gets about 3 out of every 4 plasma cell tumor.
okay.
Performance is lower than in the like a lymphoma, a
Okay.
straightforward lymphoma. So
Okay.
when I hear PAR is polyclonal, that doesn't prove to me
That
yet
it's not.
that it's not neoplastic. But I think combining that with the electrophoretic profile and that immunofixation, I'm comfortable saying this is inflammatory. This is polyclonal. I just don't know what it's targeting at this point.
Well, and it's also going to be interesting because now that his squamous cell carcinoma is gone and his thyroid tumors are gone.
Right.
And you did say he had cystic lymph nodes, and I meant to ask, were those systemic or are those limited to certain, are they abdominal lymph nodes? I do have
Just
to apologize.
abdominal.
Go ahead. Sorry. Yes.
Just abdominal. All of
Abdominal.
his peripheral lymph nodes were normal.
Okay.
Okay.
So we do have a time limit. I apologize. They need this account again for other groups, and I knew this was gonna be a long case. So we will reconvene in June for a different discussion, and hopefully we'll be able to help Mandy provide some. If anybody has any guidance, try steroids.
That's
dog
my
is on
suggestion. Look for the
steroids.
Okay, he's already on
infection and try
steroids. Okay.
steroids.
Okay. Thank you so much, guys. Bye.
Okay, thank you guys. Bye.